Anyway, it's fun to be back again. I'm going to be more on the clinical side because that's what I am, a clinician. But I was asked to touch on pulmonary rehabilitation. You've already heard discussions about pulmonary rehab already in this symposium. I'm going to go into some of the science and some of the challenges in getting pulmonary rehab to patients who need it. So, objectives, rationale, components, evidence base, and then my last section is expanding this into the home. Again, same disclosures I had the last time. So I want to break my 45 minutes or so into these sections, rationale, what is pulmonary rehab, or why is it important, the structure, how it's currently given, which is mostly center-based, the evidence base supporting pulmonary rehab, and it's growing really rapidly, and it's incredibly positive. And then, as I say, the sort of hot topic of today is going beyond center-based pulmonary rehab, specifically moving into the home. So rationale, use it or lose it. This is a phrase that's been around for a long, long time. It's sort of interesting. In the first half of the 20th century, and yes, that was before my time, chronic disease sufferers were usually told to go to bed. You got heart disease, go to bed. You got lung disease, go to bed. You got a bad arm, go to bed. People just went to bed. The neuromuscular folks were the first to kind of recognize this may not be such a great idea. My sister-in-law broke her hip last week, and they pinned it. And we went and visited her a couple of days ago, and she was in bed. And I said, "Do you get out of this bed?" And she says, "No." And I said, "Well, do you do anything?" And she said, "No, because I hurt too much, and I'm dizzy, and I don't feel well, and everybody just says, stay in bed." I said, "Does physical therapy come by?" Not obviously as good as you, but who says, "Oh, you poor thing," and tries to move her leg around, it hurts too much, and she stays in bed. And I think this is a terrible idea. But I'm an in-law, and I gotta watch what I say. Anyway, the neuromuscular and the orthopedic folks first recognized this in the 1930s. Physical therapists did the same thing. They recognized this as well. And use it or lose it. In the 50s, the cardiologists caught onto this and said, maybe heart failure doesn't need to go to bed. And cardiac rehab programs emerged, first for congestive heart failure, and later for post-myocardial infarction care, and post-ops. And the cardiologists were smart. They realized it was more than just getting them up out of bed. Education was important, nutrition was important, occupational therapy, physical therapy were all important. And they also started to grasp the idea that psychosocial support and lifestyle modification were important. So rehab is kind of turning into a total disease management program. And I think that's good. Finally, the pulmonologists pulled up the rear here and recognized in the 60s and 70s that, hey, this might work for pulmonary patients as well. There was a lot of discussion that said, oh, you can't exercise a lunger because their lungs won't let you. Well, that turns out not to be true. And I'll show you some data from my own program that shows very clearly that deconditioning, cardiovascular deconditioning, is a major, major driver of functional impairment in COPD. Patients are not always ventilatory limited, and they can exercise, and they can get benefit. But it took a while for the community to sort of catch on to this idea. Key developments, major organizations have finally bought into this notion. The NIH, American Thoracic Society, ACCP, they're all recognizing it. A number of evidence-based reviews have come out saying that this is really a good idea. GOLD, the Global Obstructive Lung Disease group, caught onto this a number of years ago and said, yeah, this is grade A evidence. The AACVPR was formed, the American Association for Cardiovascular and Pulmonary Rehabilitation was formed, and came up with certification ideas, a lot of guidelines. The National Emphysema Treatment Trial was very interesting. For those of you who don't know about it, the National Emphysema Treatment Trial was one of the first partnerships between CMS and NIH to do a clinical trial. By law, here we go again, NIH is not supposed to do clinical care, and by law, CMS is not supposed to do research. So lo and behold, by some act of the gods, they actually were able to work together. CMS said they would pay for the patient care aspect of this program, and NIH would fund the research side. And it was set up to look at lung volume reduction surgery. Lung volume reduction surgery. This was a technique that caught on, back in the 90s? Big hyperinflated lungs, flattened diaphragm. Let's go in there and cut out hunks of lung, allow the diaphragm to resume its more normal position. Patients are going to get better. Everybody's going to be cured. And a lot of people started doing lung volume reduction surgery, including a lot of crazy quacks who did really strange techniques to get the lung volumes to get smaller. And so by the late 90s, NIH, CMS, everybody said, whoa, we got to look at this. And so they developed this clinical trial that was a partnership between NIH and CMS. Truly a remarkable step in clinical trials research. There have been others since then, but this was the first one, NET. So why am I telling you about NET and pulmonary rehab? What the heck has that got to do with anything? Well, it was sort of interesting because at the time, CMS did not recognize pulmonary rehab. They said, here we go, going back to the law, in the 50 or so benefit categories of CMS, rehabilitation was not one of them. And so CMS said, we cannot pay for rehabilitation. But then we were doing this trial of people who were going to get lung volume reduction surgery. And CMS said, well, you know, I know we don't pay for it, but maybe people ought to get rehab before they get subjected to lung volume reduction surgery. And of course, we on the steering committee says, hey, excuse me, you're the deniers out there. You're the ones that say this is not something that you can fund. And they said, well, we just won't call it rehab. We're going to call it education and exercise training pre-op. I said, okay, whatever you want. You can do rehab, just don't call it rehab. Anyway, the reason I'm telling you this story is because it turns out that in these patients, desperate for dyspnea, functional impairment, desperate enough to undergo an experimental surgical procedure, 15% of them opted out of the program after they went through rehab. They said, wait a minute, I feel much better now, screw this experimental surgery, and they quit. And CMS caught on to that and said, whoa, you mean we can save 15% of these lung volume reduction surgeries by funding pulmonary rehab? And that's the story of the opening at CMS for paving for pulmonary rehab. And the G codes they used back then, which are temporary codes, and they were designed just for the study, have continued to exist ever since. It's kind of an interesting story about how things evolve. Rehab is recognized by CMS. It doesn't pay as well as it should, and that's another story unto itself. In my own program, we use physical therapy as our main source of access, or therapy. And CMS recognizes pulmonary rehab. They don't call it pulmonary rehab. They don't call it that, but they recognize the services, and it qualifies as a PT benefit if you jump through the right hoops. So anyway, sort of a sidebar story there, but I think it's a fascinating piece of history about how CMS, NIH, and common sense kind of came through at least once. And anyway, the reimbursement battles, as they say, are slowly succeeding. We're making headway, but it's slow. So what is rehab? It's a comprehensive approach to the management of chronic lung disease. It's based on the following concepts. Dyspnea, inactivity, magnify functional loss. Medications and other therapies are complicated. Chronic disease is accompanied almost always by depression and anxiety. The traditional center-based programs will last anywhere from 4 weeks, which is on the short side. My program is on the short side, but we do it every day, and we do it for several hours a day. Excuse me. Most programs will last out to 12, 16 weeks, and Medicare has funded them I'm not even going to tell you the number because I always forget it, but it's somewhere up in the 20s. Maybe 30s, I can't remember. Don't quote me. It's a triad, as I say, of education, exercise, psychosocial support. And I'm going to come back to this point over and over again. It is not a 12-week or a 4-week program. It's lifelong. This is a lifelong change and it's a lifelong disease management program. The key components, as I say, education, exercise, psychosocial support. Education, chronic management is sort of straightforward. I'm a big believer in the acute education, management of acute diseases, because I think patients are capable of managing themselves in anticipation of disasters once they've gone through pulmonary rehab. They understand their lungs, and we are big proponents of most patients having ready access to an antibiotic, a Z-Pak, something like that. And in most patients, not all, but in most patients, also a Medrol pack. No, I'm not talking about lifelong steroids. I'm talking about a short pulse of 6 days. And just have ready access to this, either a prescription on file or actually the medications in their medicine compartment. We don't have time to go into the details on this, but a number of studies have shown that these really do reduce exacerbation frequencies. That's not to say it's not without some problems. One big VA study said if you get too glib and don't give the patients access to hotlines and access to hotlines, professionals who can help them when they're not doing well, you actually can create a false sense of security, and they may not go to EDs when they really do need to. So you got to be careful in these self-management programs that you've got them understanding exactly what they can do and what they shouldn't do. Exercise, this is a backbone of pulmonary rehab and other rehab programs. Deconditioning is common. You may need bronchodilators and oxygen. So, excuse me. The impairment in chronic lung disease is multifactorial. We talked about some ventilation impairments in my last presentation. These diseases often are associated with VQ mismatching, ventilation perfusion mismatching, and hypoxemia. Excuse me. Where'd that come from? The heart is involved, even in chronic pulmonary disease. The right heart doesn't work, it gets overloaded, and this can lead to dysrhythmias and poor cardiac outputs. And again, I've mentioned this before, I'll mention it again. Deconditioning, both from a cardiovascular point of view and from oxygen extraction capabilities at the peripheral level. This is, well, it's not that old a study. One of my fellows did it, looking at patients coming to our program, looking at the number one cause for functional impairment. We did full-fledged exercise tests. But it's sort of interesting. You'll notice cardiovascular. Now, cardiovascular in our exercise facility, or testing capability, only measures heart rate, blood pressure, and rhythm. So we can't separate deconditioning from true heart disease. Wow, I don't know where that came from. But I want to point out that it's not ventilation. Remember I mentioned before, a lot of people were afraid that ventilation limitations would limit patients. That only happens about a quarter of the time. So patients can be trained, and deconditioning is likely to be a major component. I touched on this in my last talk as well. Skeletal muscles don't work as well. And these patients they don't have COPD in isolation. They've got orthopedic problems, they've got metabolic problems, diabetes, obviously. They have dyspnea, and this limits them, and they're afraid. They're afraid. So the rationale for exercise is fairly straightforward. Cardiovascular and muscle conditioning is possible, and it's desirable. And there are other mechanisms at work here with exercise. Patients learn they can do it. They're less fearful. They learn to tolerate their dyspnea, and the mechanics of exercise can be, I think, benefited considerably by OT and PT involvement. So exercise training, intensity, type, frequency, duration, medications, oxygen. This is a nice study. It's fairly old. I don't have the date on it, but it's from the 1980s that looked at changes in and exercise capabilities with a low training work schedule versus a high work rate schedule. And you'll notice improvements in lactate, reduction in the need for ventilation. Those are reductions in VO2 and VCO2 at max exercise, so they were more efficient. Heart rate went lower. This is showing you that high work rates in these chronic lungers are desirable. And I'm going to touch on remote PR, just like Dr. Landon did earlier. But this is one of the things that worries me a little bit, is can you crack the whip in the home as well as you can in your center-based facility? That's a question. I don't have an answer. So higher the better. We like to try to push people to 80% of their maximum heart rate if at all possible. We have all kinds of different tools or different pieces of equipment. That's a cystic fibrosis patient on the left. Here's a chronic lunger on oxygen. Aerobic exercise, stretching, strength training, walking. A lot of controversy as to whether you ought to use resistive breathing. I'm not a real believer in resistive breathing. I figure these people have got enough airway resistance, thank you, just the same. And adding more resistance, I'm not sure, is a real benefit. But they're believers, and there are some small studies that suggest maybe it's a benefit. So I'll learn as we go along. The type, I love this. Michael Bellman told me this before, a long time ago. I said, should we walk them? Should we ride them? Should we put them in rowing machines? He said, Neil, whatever the patient wants to do is what you should use. In my program, the patients love the you got to help me here. New step? No, not the new step. The one you sit on, and it's a reclining bicycle. I'm sorry? It's a recumbent bicycle, but it's got a fancy name to it. I can't remember it. Oh, good. I feel better. I thought I was the idiot here. Anyway, whatever the patient will do. But the patients in my place do like this sitting. They like to be able to sit, and it's a cycle. It's a sitting cycle kind of device. Frequency, at least 3 times a week. My program does it 5 days a week. The duration, at least 20 minutes. We actually do 2 sessions in each of our daily visits, which is a lot. So I guess we're at the extreme, the high intensity extreme. Can't emphasize enough, lifetime. You can't go and do this and then quit. This shows you, this is how long it actually takes to get where you want to go. These are number of sessions, and you can see to get the work rate up where you want it, it may take you up to 18 sessions. These programs cannot be done in a week. Cannot be done in a week. This is the most depressing slide I'll show you. This shows you, this is an old study, but I love it. It shows you all the things that are happening in your muscles as you exercise and condition yourself. And your enzymes are better, and your capillaries are better, and your oxygen delivery is better, and everything is really cool, except look what happens when you stop. It drops like a stone, and it drops really fast. That is, to me, is horribly depressing. But it is what it is, and I think it's a reminder to all of us that maintenance is critically important. Lifelong exercise is essential, and it has to fit in with your lifestyle. Maybe some people just want to go walk in the mall 2 or 3 or 4 times a week. Maybe other people want to actually invest in fancy equipment. But it needs to fit in with their lifestyle, and they need to do it. And some sort of monitoring seems important. Maintenance is better done as part of a partnership with some kind of healthcare facility than trying to do it on your own. Interesting enough, I showed you those depressing exercise data that shows how it falls off. Quality of life does seem to be more durable than exercise effects. Andy Reese showed us that a number of years ago. So medications, you want to optimize bronchodilators and may need bronchodilators pre-exercise. We don't see exercise bronchospasm a lot, but it does occur. And a lot of people, even without demonstrable improvement in FEV1, find that a quick whiff of albuterol before exercise can help. And finally, oxygen. Resting oxygen doesn't always predict exercise desaturation. There certainly is a correlation there. But you need to measure exercise oxygenation. You can see people here can have very high resting PO2s, and yet their exercise PO2 is in the toilet, and vice versa. This is an interesting study. This is Rich Casaberry's study looking at oxygen. And these are people, these are all COPDers, and they are not hypoxemic. They don't drop below 90% saturation with exercise. Yet he gave them, the ones in the black dots, oxygen to exercise with anyway. So he didn't need it by pulse oximetry. But look at that. They have a pretty consistent improvement in work rate using supplemental oxygen. Now that's kind of an interesting idea, and Rich has speculated why this might be the case. His theory is that, and it's a reasonable one, is that even though your PO2 is not in a critical range, even you and I in the room with PO2s in the mid-90s, we have some carotid body stimulation from hypoxemia, even though we're not hypoxemic. There's just a tonic discharge from the carotid bodies. And if you raise your PO2, you and I, it will quiet that carotid body discharge down. So maybe it's just allowing them to tolerate dyspnea better. I always used to laugh at football players. You've seen them. They come off the field and they grab their oxygen mask and, oh my God, they seem to feel 1,000 times better. When I used to laugh, well, they probably took their saturations from 99 to 100. But in fact, maybe there is a physiologic benefit to a little bit of hyperoxia, at least a little bit of hyperoxia, in making you tolerate dyspnea. That's a speculation on my part, but the data are what the data are. A corollary to this, do I have time? Yeah, I'm okay. I always have stories to tell. Fascinating study out of Israel. Why Israel? Israel has the Dead Sea. What's such a big deal about the Dead Sea? It's below sea level, so the PiO2 is higher. It's still 21% oxygen, but the barometric pressure is higher. So the PO2 they're inhaling is higher. And rehab at the bottom of the Dead Sea seemed to have better outcomes than rehab at sea level. Kind of cool. A little trivia question for you. Where's the best place on earth to do pulmonary rehab? And the answer is the Dead Sea. You all are probably familiar with the LOT trial. This followed the NET trial. This was looking at oxygen use in patients who were not hypoxemic, or at least not resting hypoxemia. They had exercise hypoxemia. But at rest, while sitting in a chair, they were fine. And giving them oxygen, what benefit did that have? What benefit did that have? Well, in fact, it did seem to improve their exercise testing while they were breathing the oxygen. But in terms of long-term outcome, with things like exacerbations and especially mortality, there really wasn't much benefit. So if you're not hypoxemic, but you have exercise hypoxemia, oxygen will help you improve your exercise performance. But unfortunately, that doesn't seem to translate, at least in a big way, to things like mortality. I showed you these slides earlier, but just I'll bring them back again. This is looking at hypoxemic patients with hypercapnia using a small ventilator and a portable ventilator. And again, to remind you, the ventilator did not improve oxygen by itself. I'm not surprised. Ventilation doesn't have oxygen necessarily attached to it. If you gave them just oxygen but no ventilator, that certainly helped in terms of work rate on the left, dyspnea on the right. And if you put the two together, you got an extra bonus. So I touched on this. A lot of people are exploring the idea of using a portable ventilation system of some form along with oxygen therapy in patients with COPD and hypoxemia. So again, there's some rationale here. Unloading the respiratory muscles gets you better exercise tolerance. And we know better exercise tolerance translates into lower exacerbation rates. So the study looking at whether this ventilation system actually reduces is the cause, or whether it's just an incidental association, we don't know. We don't know that yet. But it's an interesting idea. So Oxygen, it improves exercise, not outcomes in exercise desaturators. Should we use it in everybody? I don't know, it's kind of an interesting idea. But I'm not ready to recommend that yet. Should we couple it with a vent? Interesting idea. I don't know about that yet. Those of you who are in the rehab business looking for research projects to do, these are two goodies, two low-hanging fruits to study. Looking at exercise desaturate, or people who are not chronically hypoxemic at rest, does that oxygen help them with exercise and outcomes? Does a vent help? I don't know. I don't know the answer to these. Psychosocial support. This is often forgotten, but if people who have looked at it carefully, there is bad neuropsych dysfunction in COPD. Cognitive deterioration in all sorts of ways, and even some people have described an Alzheimer's type dementia. And the mechanisms of this are obviously multifactorial. Long-standing respiratory acidosis is probably not too much of a cause here, but hypoxemia almost certainly is. Almost certainly is. And then remember what I said in my last talk. COPD is not just lung disease. It's a systemic disease. And the systemic effects of chronic inflammatory cytokines circulating probably do have profound effects on the neurocognitive system. So these are real effects in COPD. Significant depression, significant anxiety. How do you manage that? That's the subject of a symposium, really. Exercise actually helps. Exercise has been shown to help neurocognitive function in and of itself. Another thing that helps is group support. We used to incorporate formal psychosocial, we had a psychologist that would come to our program and do group sessions. And we found out, published this in Chest probably 20 years ago now, that the group sessions really helped, but the psychologist was unnecessary, which disappointed the psychologist who wrote the paper. But I was impressed that he at least demonstrated that just exercise and group support alone can have profound benefits. And then the use of medications is probably important, but it's not been studied very well. I'll leave it at that. So, education, exercise, psychosocial support. The evidence base, there's a fair amount. Exercise tolerance, quality of life, psychosocial functioning, healthcare costs. These studies have been going a long time. People say, Neil, don't you have a newer one than this? 1996, that's 25 years old. There are newer ones, but I like this one to show you that we've known this for a long time. We've known this for a long time. This is looking at exercise tolerance, multiple studies, 25 years ago. This is not a news flash. The AACVPR and the ACCP have reviewed the literature. They give it grade A evidence, especially for lower extremity exercise. Gold in 2013 finally gave it grade A evidence for exercise training. The literature is quite strong here for exercise tolerance in pulmonary rehabilitation. Dyspnea, similarly, grade A ratings from all these big groups, including Gold in 2013. The mechanisms are multifactorial. Again, we could speak for hours on this issue. Quality of life and psychosocial function. Grade A evidence for quality of life improvement. Grade A evidence for improved psychosocial function. As I mentioned a moment ago, not sure you need a psychologist. Again, just to perhaps date myself, this was the very first study I did in our pulmonary rehab program. This was published, I don't have the date on there, but I'm going to guess it was probably about 1999. And this was looking at the PGWB, probably a tool none of you have heard of, and I never heard of it before, and I haven't heard it used since, but I liked it, the Psychological General Well-Being Index. And this was looking at our own program of over 100 patients, and you can see it gets pretty impressive. The improvement in all these subscores, many of them actually getting up to 100% of the normal scale, which is pretty cool. The notion that we could keep people out of hospitals has been around a long time. These are also, again, people say, Neil, why don't you show new stuff? I will. But I like showing the old stuff to show you we've known about this for a while. We've known about this for a while. These are 3 studies, one of which is my own, looking at hospital days pre and post program. And notice it goes out 4 years. the reduction in hospitalization. Okay, I'll show you some newer stuff. Here's some newer stuff so for you guys who insist on newer. But even this isn't that new, mid-2000s, early 2000s. But I want you to notice these are all randomized trials, all looking at healthcare utilization. And as you can see, the little stars which indicate significance were found in every one of these studies. Reductions in COPD, AE-COPD, hospital days improved, et cetera, et cetera, et cetera. This is a meta-analysis on some of the better studies showing that AE-COPD is reduced. And mortality appears to be reduced. Now, I had to put a disclaimer in on this one. You'll notice this meta-analysis is being driven heavily by Terry Truster's study there, number 3, which I think to this day still hasn't been published in a journal. This is from abstract data. I could be wrong, Terry, if you are listening to me, and I apologize, but at least up until recently, it had not made it to the peer review literature, only in abstract form. But I'm not surprised. Mortality would be a hard endpoint to improve. But I think reducing hospitalizations is pretty convincing to me. So again, an evidence-based summary. It's grade B evidence for hospital cost reductions. Those studies I showed you were small. But Gold nonetheless gave it a grade A recommendation. ATS statements are clearly state PR is cost effective, and my own program, I had to put a plug in here. Chris Mosier went back 5 years and looked at the cost savings of pulmonary rehab. He did a very elegant cost effectiveness analysis that just got published this year. I'm proud of Chris. It's a nice study. So, a lot of outcomes that seem to be quite beneficial. And now, what have I got? 32 minutes. So I got about 13 minutes to cover probably the biggest topic. Can you take this outside the home? And Dr. Landon gave a nice review of techniques to do this. Is it possible? Is it effective? So there are significant barriers to PR, pulmonary rehab, both initially and for maintenance, transportation, finances, convenience. I have to show you. Yeah, 13 minutes, I got enough. I had this brilliant idea a few years ago that I could improve access to my pulmonary rehab program by renting a bus. And I actually had a small grant to allow me to do this and pick up people who said they just couldn't get there. And I was really happy with this, and we were about ready to implement it until the lawyers came and said, Neil, you can't do that. And I said, why not? That makes sense, doesn't it? He says, that's Medicare fraud. I said, whoa, let me get this. A bus to bring people to a therapy that will benefit them is fraud. Our government at work. The bus was considered an inducement for people to come to my program. I said, well, that's right. It is an inducement to come to my program. But for what I thought were the right reasons. Anyway, my bus never got off the ground, which is really unfortunate. What's that? It never got rolling. Yeah, it probably was on the ground, but they weren't flying to my program. You're right. So this, of course, brings up the inevitable question that Dr. Landon touched on. Actually, more than touched on, he discussed it a lot. Can you provide PR in the home? You're going to have to do different exercises, and you're not going to have the same equipment. The regimens are going to have to be, a lot of them are going to have to be self-managed. There are safety issues, frail patients, hypoxemic patients, patients who have bronchospasm. Education can be done remotely. That's probably the easiest thing. And how much supervision and medical intervention? Been a lot of studies looking at comparing outcomes. And like I said, I hinted at this before. I'm worried about the exercise being as intense as perhaps it could be. And again, there are safety issues. So these are big slides with lots and lots of data on them. I'll try to summarize them as best I can. These are a number of studies that have looked at functional status, top panel, quality of life, bottom panel, compared to usual care. So this is taking home-based PER and comparing it to nothing. Some people say, well, that's not a fair comparison. You ought to compare it to pulmonary rehab at a center. And well, I understand that, but let's get real here. As you heard Dr. Landon mention, 95% of patients who are eligible for pulmonary rehab don't get it. Don't get it. They are at home getting nothing. So showing that PR is better than that, actually, to me, makes a lot of sense. I'm not trying to put center-based PR out of business. I'm trying to get access to the people who can't get to center-based rehab for whatever reason. So I think the studies comparing it to usual care, I like those even better than comparing it to center-based rehab, although I'll show you those data as well. So the fact that you may not get as good an outcome as center-based rehab may not be as important as you think. It may be okay, it may be just as well, you may be doing just as well, or not, maybe not just as well, but at least performing an important service compared to, quote, usual care. And as you can see, these studies, those of you who are not used to looking at these forest plots, they're summarized best by looking at the magic little, turn around here so I can see it, the magic little black diamond right here. And what that little black diamond is it's a summary of all the studies. These are the studies looking at quality of life, functional status versus usual care. What, 1, 2, 3, 4, 5, 6 studies. And that's the summary of all 6 studies. And if the diamond ends up to the right, it favors home-based pulmonary rehab. If the diamond ends up on the left, it means usual care is better. If the diamond ends up right on this line, it means it's a wash. It's a wash. So the further the right this diamond is, the more positive your results. And if the tip of the diamond doesn't touch the line, it means it's statistically significant. So that's how you read these meta-analyses. I suspect many of you are familiar with these, but just in case, I want to make sure everybody knew how these plots were constructed. So this is for functional status, usually exercise testing, and this is health-related quality of life. Why they flipped it so this is better on the left, I'm not sure, except that most of these scores, the lower your score, the better your quality of life. And the higher your score over here, the better your exercise capability. So the diamond here is well to the left, indicating pulmonary rehab in the home dramatically improves quality of life. So these programs, compared to usual care, are really quite good. Now again, purists say, well, how did it work compared to center-based rehab? Well, not bad, not bad. In fact, you could say the fact that it came out pretty darn close is good. I don't think anybody would try to tell you that home-based PR is going to be better than center-based. If you can just show that it's comparable, you've done something. So again, same design setup. Now the diamond favors center-based rehab, but the tip of the diamond crosses the neutral line. So even though this is a trend that center-based has better exercise performance, but it's not statistically significant. But the fact that it's close in and of itself is positive to me. And this is looking at, again, health-related quality of life. The diamond sits right on the 0 line. I don't think that's bad. It means that quality of life is similar, or quality of life improvement is similar with center-based and home-based. So to me, that's a win for home-based programs. So this is, these are data that are quite supportive of the notion you can take these concepts and put them in the home. And we could spend a seminar talking about all the different ways of doing it. Do you need telemedicine? Do you need a Zoom? Do you need to call them? How often do you need to call them? It's a lot of different approaches have been talked about. So how much supervision? Supervised exercise is more effective than non. I think this is an important point. It goes back to what we were talking about before with non-invasive ventilation. You need clinical input, period. Period. Now, whether it is by phone, whether it's by personal visits, whether it's by Zoom, whether it's a combination of all the above is not clear, but you need personal input. And I can't emphasize that enough. You need personal personal input. You don't want to put patients out on their own. And this has been shown in multiple studies, multiple times. And lifelong maintenance, just like the acute phases or the early intensive phases, also needs some supervision. Some supervision. You've got to have people looking after you. You've got to have hotlines. You've got to have continued, let me emphasize this again, lifelong support to make these programs work. How about for maintenance therapy? How well are these home programs for maintenance therapy? And again, we have a forest plot here looking at supervised in the top panel, looking at unsupervised in the middle panel, and then a kind of a mishmash of mixtures of going back and forth. And as you can see, the diamond for supervised maintenance programs, it's positive. It favors formal maintenance programs for a lifetime. For a lifetime. You can see if it's unsupervised, the middle panel, you don't get much benefit. And that's a pretty consistent finding. And down at the bottom, if you kind of flip back and forth between the center and the home, that seems to also be beneficial. So the take-home message here is not only for the quote-unquote intensive phase of pulmonary rehab, but for the maintenance phase of pulmonary rehab. And this may be actually a bigger role for home-based PR than the intensive phase. Because this would be for everybody, those who both get a center-based program and those who do it in the home. So I think this is an untapped area for maintenance remote pulmonary rehab. Just as a disclaimer, I noticed Dr. Landon was talking about companies that are out there trying to get this done. I am not an employee. I do not get paid by these folks. But this is a platform that has an SBIR, Small Business Innovative Research grant from the NIH, and I'm on the steering committee for this program, and we are doing exactly what I described a few minutes ago. We are looking at pulmonary rehab not as an alternative to center-based, or not comparing it to center-based. We're looking at it in real-world terms, out in the community where people who cannot, for whatever reason, do center-based pulmonary rehab. And looking at a large population, this is an automated system. It does have personal supervision. I insisted, I didn't have to insist very long. The steering committee was well aware of the importance of supervision. But this has clinical supervision, but it's a nice platform that uses avatars and a lot of cute cartoons to guide their rehab program, both for both for the intensive phase and for the long-term maintenance phase. So it's kind of cool. I'm not trying to plug them. I'm not an employee. I don't get paid. My only involvement is that there is research funding that does come to Duke to help us evaluate this particular product. But there are others like it. There are others like it. Dr. Landon was talking about other programs out there. This is certainly not the only one. It just happens to be one that I'm sort of familiar with and am doing research with. So, 43 minutes and 33 seconds. Spot on. I tried to cover why pulmonary rehab makes sense, why it should offer benefit to people with chronic lung conditions. We've been talking mostly about COPD because that's where the literature is. I'm a strong believer that this is really good for any chronic lung disease. We have a fair number of interstitial lung disease patients. I didn't have time to go into it, but there are data supporting good outcomes in that population as well. And that's not surprising. The mechanisms of impairment are very similar. Yes, it's not obstructive airways, it's stiff lungs, but the loads on the muscles are similar. The structure, the center-based structures have been around a while. Education, exercise, psychosocial. The evidence base is really quite strong. There are very, very few negative studies. This concept works. And I think there is a role in the home. We're still learning now about the best way to do it. So with that, I'll shut up at, God, I'm good, 44 minutes and 38 seconds. Thank you all very much for your attendance. So again, we have about 5 minutes if anybody has any questions or comments or concerns.
How does your clinic compare to the Duke basketball facility in regards to equipment?
You're going to get me started here, man.
I have 5 minutes.
Yeah.
Cameron Indoor Stadium is an iconic place to watch basketball. It's an old building that has all the modern amenities inside. It's kind of interesting. If you look at it, you say, my God, this thing looks like an old high school gym. But you go inside and you realize that it's fancy seating and big concourses and all kinds of stuff. It's first class, even though it looks like something out in the 1930s, which of course it is. Our rehab facility, fortunately, we've been blessed. We have what we call the Duke Cardiopulmonary Rehabilitation Center. It's a dedicated building with with the indoor track and a lot of exercise equipment, classrooms, offices, and the like. So we're blessed with a pretty good program. I realize not everybody has it. Yeah, I saw it. Yeah. You're bringing up an important point. The home-based programs are going to be, I think, snapped up by people whose big problem is transportation, access, and the like. But you bring up a very important point. It's sort of the 800-pound gorilla in the room, isn't it? The American population does not, as a whole, embrace going out and exercising. Yes, I know there are lots of people who exercise. I get that. And that's true of chronic lung disease patients as well. The motivation, the desire to do it is a major barrier that we don't talk about much. And the home-based program, if they don't want to do it in a center, they may not want to do it in the home either. So you bring up a very valid point. I think, but again, for those patients in whom the real issue is maybe finances shouldn't usually be a problem, but it can be. But mostly it's transportation and access. Their home is 50 miles from the nearest center-based facility. But you're right. If a patient doesn't want to do it, you're screwed. Yes?
In your program, have you considered or are you even able to partner with home care therapists to provide it in-home?
We have not gone that route. I told you we're really right now, our home-based focus is in research. We have this grant and we want to use it. And anybody who even mentions home-based programs, we steer them into the research program. Assuming the research program is legit and this particular product looks like it works very well, obviously partnering with home care is going to be critical. So we'll use you in the intensive program and your husband in the chronic program. Okay, thanks again for inviting me here. It's been a lot of fun.